Hello, everybody, and welcome. Thank you for joining today. I'm Carol Horowitz. I'm the founding director of the Institute for Health Equity Research, or IHER. On behalf of Lynn Richardson, my partner in the Institute, who is right now cruising on the Mediterranean, so she couldn't be here today, I want to welcome you. IHER's mission is to bring together diverse collaborators like us, so we generate evidence and innovate solutions that drive equity in health and healthcare. We established this seminar series because we want to amplify important work of renowned health equity researchers like our speaker today and our partners so we continue to learn from, learn with, and support and fire each other up. So, Dr. Alicia Fernandez, I have known you for longer than I know my own kids, and my oldest kid's turning 30 this weekend. You are the definition of an equity to action scholar. Your groundbreaking research on language, on literacy, on workforce diversity, the impact of racism and social determinants on healthcare and health. You are an incredibly gifted and generous mentor. Anyone who gets to learn with you is very, very fortunate. You magnify the power of community-centered research, and you are a clear, unambivalent voice for social justice. So for everyone else who's here, to give you an idea of why we had to wait patiently for her to have time to teach us today, at UCSF, Dr. Fernandez is a busy primary care provider, professor and associate dean for population health and health equity, a founder and director of UCSF's Latinx Center of Excellence, and nationally, among many leadership roles, she's a member of National Academy of Medicine, ABIM Board of Directors, PCORI Board of Governors, and newly appointed to the U.S. Preventive Services Task Force, which I'd love to hear about. And with all the disruption, chaos, uncertainty, and upheaval we're facing, she follows her own recommendations in her recent New England Journal piece, Keep Your Eyes on the Prize, Focus on Equity. Dr. Fernandez is an inspiration, and you're all in for a real treat. We're going to leave 10 minutes for Q&A at the end of the talk, so please submit questions in the Q&A section of the chat, and welcome. Dr. Fernandez, you're on.
Thank you so very much, Dr. Horowitz. As you say, we go back, way back, and I couldn't have been happier when you invited me to come and speak, and I'm just really delighted to be here. And as a long time fan of your work, it's just such a pleasure to be with you. I'm glad Dr. Richardson is on vacation, but I also so appreciate her work and the center that the two of you run. So thank you very much for inviting me. I look forward. I hope this will be a useful talk for folks. I'm going to go ahead and talk about advancing language access equity through research. And okay, this was working a minute ago.
Try to click on the screen. Maybe just click on the screen and then maybe it will start advancing. There you go.
There we go. I have no disclosures. I think it makes sense to tell you a little bit about where I work because I think we're learning more about how positionality is important in research. I'm at San Francisco General Hospital. That's a nice view of the hospital with the Bay Bridge beyond it. We we are the sole level 3 trauma center for the city. The hospital is very well known for HIV and for trauma, as well as for research. And we have about 40 different languages spoken per month, over 160 different languages spoken per year. We provide interpretation through our own set of interpreters and through a commercial language line service. And then even though my own panel is relatively small as someone who primarily does research, I have all sorts of languages spoken by the patients in my panel. And the reason that that's important is that I'm on all sides of the language divide. And while much of my research is in Spanish speaking patients, which is a language I do speak, there are plenty of languages. I don't speak any of the other useful languages my patients speak. So I'm very used to this. So Thinking about this talk, I wanted to focus primarily on two issues right now, which is what do we learn about health communication from this? And then I wanted to talk a little bit about technology, as I know that it's something that many people are thinking about. So we'll talk about language barriers and context, just to level set the literature on patient-centered outcomes and clinical outcomes, and then talk about innovations in machine translation, interpretation, and research agenda. I think you all know that places like California and New York are highly linguistically diverse. In San Francisco, 43% of the city speaks somewhat a language other than English at home, and 19% report on the census that they speak English less than very well. Of the 68 million people who speak a language other than English at home, that number has grown. Here you can see it in the orange, that in absolute terms, that number has grown. And then the other point that I want to make here is that overwhelmingly the majority language is Spanish. So about 62% of people who speak other than English at home speak Spanish. The census then groups all the Chinese languages, Mandarin, Cantonese, Toisanese, etc., and all of those grouped together into what they call Chinese is only 5% of the language other than English at home. And then you can see the next ones in order. An important concept to elevate, and one that I'm sure you all are familiar with clinically, is households with linguistic isolation. Because here, for Spanish speakers, only about 22% of those households are linguistically isolated, where no adult speaks Spanish. On the other hand, for Chinese, Korean, and Vietnamese, about a third of those households are linguistically isolated, making it very difficult for those patients to make appointments or receive messages, etc. So I've always wanted to figure out a way of sort of conveying even the numeric importance of language access. You can look at this in different ways. When advocates frequently use the census categories, the answer to the question, how well do you speak English? Very well, well, not well, and not at all. Advocates often say there are 26 million people in the US that say they speak English less than very well. This is true. But there's 13 million who report speaking English not at all or not well. And those people really have a very hard time carrying out conversations cannot get along without interpreters in clinical encounters. So what proportion is 13 million people? It's about 4% of the population. And one way of looking at that is that that's equal to the sum of patients with schizophrenia, RA, hepatitis C, cirrhosis, and end-stage renal disease. And I think that might be a better way to sort of get a handle on how large this number is. So let me talk a little bit about language barriers and patient-centered outcomes. And I'll touch on three things: underuse of interpreters, comprehension, and trust and respect. So I think there's been decades of evidence on the importance of professional interpreters as improving both patient-reported and clinical outcomes. And as you all know, those are mandated by federal statutory requirements under Title VI of the Civil Rights Act. And that is what they called an unfunded mandate, meaning that no monies are set aside to pay for those required services. I think you also all know, clinically at least, that language access services to interpreters are often not employed, and that's despite having more modalities such as video interpretation available at many sites. So it's been interesting to try to get a handle on how much underuse there is of interpreters. One way of looking at it is by what health services themselves say. And in a fairly recent paper, only 70% of hospitals said they offered language services, which I was very surprised at. Um, in and in the most recent large survey that I've seen is out of 2020, where 273,000 primary care physicians were surveyed, and a third of those said that they used interpreters often when seeing a patient with limited English, but 40% of those self-reported never, that they never use professional interpreters. So I think that gives us a pretty good handle on the huge magnitude of underuse. And then, of course, there are many patient studies reporting underuse of interpreters. In fact, even in California, most patients report not having access to professional interpreters. This is an older paper of ours where we looked at where we had residents talk to us about when did they use interpreters. And they used interpreters only here in the blue, the light blue, on admission, when they consenting patients for a procedure, and in family meetings. But for example, in daily rounds, 45% reported that they got by, meaning they didn't use interpreters, they just got by on gestures and maybe one words. Similarly, for updates and check-ins, it's over 40%. Perhaps most disturbingly, only 26% report getting by alone for discharge instructions. And again, this is among 3 services: medicine, family medicine, and surgeries at UCSF, a program which tends to have quite good residents. So the question, of course, is why aren't interpreters in use more? And I think this falls into a classic healthcare disparity, and many of you are familiar with this figure from the IOM report, Unequal Treatment, where they looked at the difference in quality of care received by 2 populations. And they said, well, some of that is clinically appropriate, but some of it is not. And that portion that they call the healthcare disparity, they divvied up into the operation of the healthcare system and what they termed discrimination, bias, stereotyping, and uncertainty. And what we find is that when you ask people, they'll say, yeah, it's sort of I don't use interpreters because in a study that we did, which is my only study that made the New York Times, which is why I put that here, is that clinicians say, it's a hassle. If I'm just doing a check-in, it's not crucial to advance the care. But at the same time, they say, I know it's not fair. And they say, and I'm very careful to use it when it's important. So DNR, no DNR. Chemotherapy, no chemotherapy. That's when I call for the interpreter. And so essentially what they tell us is that getting by without using interpreters is an acceptable shortcut. And that acceptability is sort of, I think, in many ways premised implicitly on that those patients are less valued, because if they were equally valued, well, then it wouldn't be an acceptable shortcut, because we actually do talk to our patients when we can do so more easily. At the same time, the hassle factor, the lack of interpreter access and infrastructure, is a very nice example of that first box, which is how the healthcare system is structured. Or some people will say that's a nice example of structural racism in healthcare. This box, the operation of the healthcare system. We did a journey map to look at all the ways, all of sort of the ways in which and you end up using an interpreter, starting from the clinician or the patient self-identifying the need, all the way to an interpreter used and is recorded. And what I can tell you is that the different letters, A, B, C, D, refer to different domains, whether it's a domain of individual clinicians, if it's a domain of the healthcare setting, if it's a domain of the implementation process as a whole. This is using an implementation science, CFER mapping. In other words, what do we know at this point about the operations of the healthcare system? We know that interventions that focus solely on educating clinicians haven't worked. I did that for years. Lots of people have done that for years. We scold our residents. We tell them to do a good job and call the interpreter. And they kind of do and they kind of don't. But that the interventions that have been resulted in larger increases in interpreter use have been multimodal, where there is EMR data, that where the interpreter use is captured in the clinical record, where there is a system often to improve access to language concordant clinicians, where interpretation infrastructure is made more readily available. We'll talk about that when we talk about technology. And when there is adequate policies, leadership, and funding for interpreter services. This is a good time to mention that our healthcare systems obviously are responsive to regulatory policies and regulatory audits. And these have been missing in the world of language access. I'm happy to say that JCHO is now, or at least until now, has been auditing hospitals for evidence that interpreters were used when obtaining written informed consent for OR and other procedures. And I'm very glad about that. But there are no other policies or audits around that interpreters, for example, should be used with hospitalized patients daily. There has been a curious lack of development of tools that would ease access to interpreters. If you have a monitor in a patient's room, you can't just click on the chart and call an interpreter in most places. I don't know of any places where you can do that. And then you can't just click on something within the chart and document that patient got an interpreter at that time with that clinician, all of which would facilitate audits and hence adherence. There have been some financial incentives, mainly through the Medicaid system, that Medicaid would pay a little bit more, actually considerably more, $25 more in California in about a decade ago if people reported using an interpreter. But that did not, surprisingly, that did not result in increased utilization. And there have been no, to my knowledge, financial penalties from payers for not using interpreters. So the big levers there have been lawsuits, which have often resulted in large payoffs, but no regular built-in incentives or penalties. And then likewise, the external to the healthcare system, we have been slow to certify skills, or though that is happening more and more often. And obviously, there has been a long trend toward focusing on a diverse workforce in many ways, and yet not so much a linguistically diverse workforce. For example, within the University of California medical schools, we do not give priority for admission to people who can prove that they speak one of California's threshold languages. So technology does help. And here is where some outpatient sites and now a few other sites are placing hard stops, meaning that if the clinician must say first what language the patient speaks, and then then they must say whether they're using an interpreter or whether they themselves are certified. And that seems to really help people, prompt people to call for an interpreter. There are studies in ERs in New York, and I seem to remember that Mount Sinai was one of them, where using a call an interpreter now prompt when the patient was identified as not as preferring a language other than English also resulted in higher use of interpreters. But so what we can say is that ER is that integrating interpreter fields and reminders into clinical templates does seem to help. And more studies need to be done in that area if any of you are thinking about research projects. Let's switch gears then to see how are interpreted conversations different from language concordant conversations, and what does that teach us, if anything, about equity? So here's a polling question, and you can put your answers in the chat, or you can just answer it for yourself. If you do use a professional interpreter, how good is it? How well does patient comprehend on average compared to an encounter with a language concordant physician? Is it about the same? Is it a little less? Is it somewhat less? Or is it a lot less? And all of you are saying, yeah, that's totally unfair. You haven't defined those terms. But the answer is a lot less. How do we know this? It's hard to know. And one of the ways that we know it is from a study that was actually done at Bellevue. And what the Bellevue investigators were interested in was comparing two different types of interpreter system, a more conventional one and a UN simultaneous interpretation system. So what happened is that as the patients came into the Bellevue ER, if they were assigned to a language concordant doc, fine. If they were assigned to a doc that didn't speak their language, then they were randomized to one of these two systems. And then as the patients left the ER, all of them were asked, these are all LEP patients that don't speak English, they were all asked how well they understood, did they understand the doctor's explanation of what was wrong with them, and could they understand the care instructions? And what we see is that with either state-of-the-art system, it was under 40% for understanding the explanation and for understanding the care instructions. Whereas for those who saw a doctor who spoke their language, it was about 60%. That is a very large difference. And it is as close as we come to a randomized trial of how good interpretation is compared to bilingual physicians. Some of you may be saying, wow, only 60% of people who understood the same language, spoke the same language, understood the care instructions. That's terrible. And yeah, and that is terrible. And that is a reminder that often low non-English language preference, LEP, goes along with lower literacy. So these are, we do a terrible job of communicating with patients in low literacy. And this number of about 60%, it's a little higher for English-speaking patients in the 70s, is about right in national data. So we were also interested in this issue in terms of not only comprehension, but in terms of other things, other important factors in the doctor-patient relationship. And so here, this is a study that I did at Kaiser with my colleagues, and we surveyed Latinos, English proficient and non-English proficient with diabetes. And we asked them about trust in their doctor. And about the same number said, I don't trust, they reported lack of trust in their doctor, about a quarter. But when we disaggregated the LEP Latinos into those who had a Spanish-speaking doctor, LEP language concordant, and those who had an English, a non-Spanish-speaking doctor, LEP language discordant, we saw very large differences. In fact, those who could speak with their doctor in Spanish were less likely to report a lack of trust. They were also less likely to report that they were treated poorly because of language, and they were less likely, significantly less likely, to report a lack of respect, that the doctor didn't show respect. Now, a couple of things that are important here. One, look how that as quality markers, all of this would have been lost if we hadn't disaggregated by the language of the physicians, if we had only looked at Latinos as a group or Latinos even by language. The other thing that is, I think, interesting is that a third of all patients think we don't listen to them, regardless of what language we speak and what language they speak. So we then ask the question, why is it much harder to elicit trust and have patients feel respect when working with an interpreter? Why is it so much harder? Well, we don't know, but what we know are things that can give us a clue. We know that interpreted conversations have, I would call, a distorted architecture. They're different. The patient talks a lot less. That's because I'm talking, then the interpreter is talking, and then the patient gets to talk. So that's a lot, the patient has to share time with two people, not just one people. The other thing that we notice is that the doctor that we know from audio tapes of conversations is that the physician is much less likely to elicit the patient's point of view. And I have noticed this in myself and in the people around me. So, for example, if I'm treating a patient with diabetes who speaks Cantonese, I'm really focused on the metformin is the big pill for the sugar. You take that twice a day. The cholesterol is a smaller pill, and you only take that once a day. And I'm so focused on making sure that the patient understands me, which is obviously incredibly important, that I forget to say, what do you think about taking a medicine for your cholesterol? Do you think that's a good idea? And that is very problematic, as anyone who's reviewed the adherence literature to statins will tell you. The other thing that is very problematic is that we're much less likely to make empathic remarks. So, for example, I was doing one of those exercises and I precept in the resident clinic, and I was, I was asked to go in and observe a resident. And I observed the resident. He was working with a Cantonese speaking patient. And he turned to the resident, to the patient and said, I see you missed your your chest clinic appointment with the lung doctors. And the patient and then through the interpreter, the patient responded, yes, my mother died. And then the resident, turning back to the computer, said, I will make you another appointment. Now, what really struck me in this is that I know this resident, and the resident is very empathic. He's excellent. And what I think happens is that there's a degree of almost cognitive overload where you're interacting with a computer, you have the interpreter, then you have the patient, then you have the interpreter, and then you're focused on what am I supposed to do now? And the patient took the time to say, my mother died, and the resident never said, I'm sorry to hear that, or what happened, or whatever. So what? The answer seems to be a lot. Empathic remarks seem to be highly associated with trust building. We know that from the literature, from literature on Black-white disparities. Here is a study that I really liked because it was done in the South at a very busy cardiology center. And what they did is just run audio tapes. And what they found is that less information, so this is after the patient has had the angiogram, what they found is that less information was given to Black patients who also asked fewer questions. And that both of those things were associated with less social or bonding type statements. We all know that if a patient asks us questions, we're going to give them more information. What I think this study and many other studies have seen is that chatter that we do, hi, how are you? I haven't seen you in a while. I'm sorry, I'm running late. How is the buses? How's the subway? How's your family? All of that social chatter that we do as we meet and greet the patient is highly associated with the amount of questions the amount that we do that is associated with the amount of questions that people ask and is associated with the amount of information that we give people. And I think that is very interesting because when we fail to make empathic remarks or when we fail to make social comfort statements, social bonding type statements, we break the bonds of trust, and people are less comfortable asking us questions. So, how to think about this? I'm someone who focuses on language, but there are plenty of people who focus on culture. And what many people who focus particularly in Spanish culture say that in order to gain trust, it's important to ser simpático. You have to be friendly. That is a culturally well-received trait. And they also have commented on the role of personalismo, which is small reveals of personal life or interest in the patient's life beyond the medical. Oh, I haven't seen you. Did you go back to wherever? How was your trip? Or I have patients. My daughter is a young adult, but I have patients who know, and they always are very interested. Oh, how's your daughter? Oh, she's fine. She's working in New York. I miss her. Now let's start the visit. Those things seem to be highly important in this gaining of trust. So, to summarize, the underuse of interpreters is common. Interpreted conversation and normalized. Interpreted conversations often result in less comprehension, and trust and patient satisfaction are lower across language barriers. These things are all clear. What is less clear is what to do about them. And for the last point, figuring out exactly what can be done. So given this, what do we know about the impact on clinical outcomes? Well, there's a lot of literature on how language barriers are associated with multiple problems. More medication errors, less likely to understand prescription labels. LAP patients are less likely to know medications at their hospital discharge and less likely to know that they've had a follow-up appointment made. Language barriers have also been implicated in hospital safety in a myriad of ways. Okay, so not great. We also know, actually, I'm not going to go into that. We also, except to say that we know that different language groups have differences in mean hemoglobin A1C for patients with diabetes. In a study that we did at Kaiser, we used a survey of 20,000 patients conducted in 5 languages. And I showed here that Latinos patients, some of whom were English speaking, a minority of whom were not, were different in only a few ways. The most important one was in education. 70% of English speakers had finished high school, whereas 70% of the Spanish speakers had less than high school, and then the amount of income. But by their clinical correlations, when we took the patients who were Spanish speaking and we split them into 2 groups, those who had a Spanish speaking doctor and those that did not, we found that there was no difference. It almost looked like they had been distributed randomly, and they had been assigned to either a Spanish speaking doctor or a non-Spanish speaking doctor. And then when we looked at what proportion of patients had poor glycemic control, we found that 10% of white English speakers had an A1C over 9, 18% of Latino English speakers did, and 21% of Spanish speakers did. But when we disaggregated the Spanish speakers, there was a large difference, with 16% of those who had a Spanish-speaking doctor having an A1C over 9, but 27% of those who had a doctor that did not speak Spanish having an A1C over 9. So what did we conclude? We concluded that there seemed to be pretty good evidence, and this is after adjustment, everything stays the same. And what we concluded was that there seems to be something about language concordance that is associated with better glycemic control. Okay, that was interesting. And what we found is that there was no difference in lipid control or blood pressure control by the language status of the doctor or by whether or not the patient spoke English. So in order to try to figure this out, if you could design an experiment, you would say, okay, let's take a group of Spanish-speaking patients and let's randomize them to a Spanish-speaking doctor or not. But the problem is that there isn't really equipoise there because the literature is so clear that patients prefer Spanish-speaking doctors. And and I think it would be hard to enroll and as well as to get IRB permission. So we said, okay, we can't do that study. What's the next best thing is to take advantage of a natural experiment. And so what we looked at were switches. And so we took, within Kaiser, we took people who had switched. These are all Spanish-speaking patients, and we took people who had switched from a discordant to concordant, discordant to discordant, concordant to discordant, concordant to concordant. And what we found is that but when we looked at their A1C a year later, what we found is that the only people whose hemoglobin A1C had improved was those who switched from a doctor that didn't speak Spanish to a doctor that spoke Spanish. And in fact, we had a 14% increase in the people with a hemoglobin A1C under 8, and a large drop in the people with a hemoglobin A1C over 9. So really important, and really important for those of you who are interested in quality improvement, because here no new resources were added. They didn't get anything different. What they got was that they ended up switched. They ended up being switched to a doctor that spoke their language. And in order to make sure that people were not switching because, hey, they had hemoglobin A1C over 9 and they didn't like their English-speaking doctor because of it, we looked at a subset of patients who switched only because their doctor left Kaiser. And while the results were non-significant because of sample size, the point estimate was the same, suggesting that it really is language. And this is showing non-significance for lipids and blood pressure. So what can I say about the clinical impact? That there are multiple worse outcomes, but not all outcomes. In fact, it's really specific clinical outcomes that are worse with clinical barriers. And what those appear to be are complicated clinical barriers like glycemic control over diabetes, which is a lot more complicated than lipid control in diabetes, and areas where there needs to be some element of trust, as is often the case in insulin initiation. When people have attempted to look at this by looking at medication adherence, it's been a little bit of a mess, with some studies showing a better adherence with a concordant doctor and others showing no difference. My own study, again with Kaiser, found no difference for oral hypoglycemics. And I suspect that if there is a difference here in medications, it's in the willingness of patients to initiate or continue insulin. So adherence, So essentially, what we find when we look at language concordance in diabetes is that glycemic control is better with a language concordant doctor. We think it's a mixture of a willingness to initiate insulin and much more increased counseling on diet, which is very difficult to do through an interpreter, both because of language, because of time constraints, because of the distorted architecture of the communication in the visit, and also because of cultural differences. It is difficult for me to do very targeted, for example, dietary interventions in my Chinese-speaking patients than in my Spanish-speaking patients, because I know very little about Chinese diet. But what we do know is that patients who see a doctor, Spanish-speaking patients at least, who see a doctor that doesn't speak their language, have less trust, less comprehension, less satisfaction, and I haven't shown you the data, but more diabetes distress. So where does this leave us? Well, for clinical interactions, there's some things that we should be doing. Given the greater difficulty with comprehension and trust, we should be ensuring that we assess for comprehension using teachback or some other method. And we should take every opportunity we can to make empathic comments. And that is something that ever since I've done that literature, I have been forcing myself to do and forcing the interpreter to interpret. sometimes the interpreter won't interpret that. They're like, wait until you say something important. And I have to like stand there and say, tell them I'm very sorry their mother died. Come on. Um, in terms of less patient-centered interactions, I think it's very important to elicit the patient's point of view, and that is something we should automatically put into our work. And then finally, there is other literature in areas outside of diabetes. We did a study, for example, on contact tracing, and we found that when the contact tracer spoke Spanish, Spanish speakers were much more they reported that the more contacts and the patient was more willing to get tested. So what about health systems? I think that for health systems, some of this is clear. The need to certify and pay bilingual staff. Many health systems that don't have a lot of interpreted interactions are starting to give longer time for encounters with LEP patients. For example, at UCSF Health, they give twice the amount of time for interpreted interactions. And then finally, many systems are employing community health workers to act as both sort of language and cultural bridges and helping to cement trust and other issues. Let me touch briefly on two innovations for machine translation and interpretation. Translation, obviously, text to text, and interpretation, speech to speech. This is what we all want. We want to be able to hold something and say whatever we want, and out it comes in some language so that someone who speaks Klingon can really understand that. And we are starting to get closer. Here is a paper we did on Google Translate. This was a 2019 paper where we took real life emergency department instructions and said, hey, and put them through Google Translate, and then had professional interpreters back translate them. And what we found is that it was pretty good, but there were a lot of potential for harm. For example, the doctor wrote, hold the kidney medicine until you have a chance to speak with your kidney doctor. Now you can say, well, the doctor shouldn't have said that. English speakers won't know what that means. Hold, what does it mean, hold? But in Spanish, it was translated as hold on, keep the medicine for the kidney until you have a chance to speak to your kidney doctor. And the same thing for simplified Chinese. And then sometimes Google Translate would just make a mistake and leave things out or change it. But now, and I should have updated this slide, this study is available in the BMJ Quality and Safety Review. What we found is we use both ChatGPT and Google Translate 2024. And what we found is that things are much better, particularly in translating from English to Spanish, and pretty good in translating, not interpreting English to Chinese, but not for Russian. And that even when it made mistake, the potentials for clinical harm was small. So we found that ChatGPT was somewhat better than Google Translate, particularly for Chinese and Russian, but that they were both pretty good, quite good for Spanish. And the way that I think about it now is that it's probably okay to use these tools when definitely when you can have them overread by a human interpreter, by a human translator, but even for non-high stakes interactions, such as emergency room discharge, where the alternative is no translation at all. Unfortunately, when we did this a couple of years ago, looking at Apple, Google, and Microsoft to look at whether or not interpretation would work, what we find is that English to Spanish, pretty good, English to Mandarin, so-so, but Spanish to English and Mandarin to English were both really bad. The phone cannot seem to distinguish. If I say, ¿por qué me duele la garganta? It will translate that as because my throat hurts, as opposed to why does my throat hurt? And so there, it's clearly and then Chinese, which is a tonal language, it's really not there yet. What about for low literacy? We just did a study where we asked ChatGPT 4.0 to rewrite patient discharge instructions for patients with low literacy without omitting important context. And then we took those instructions and we showed them to patients at San Francisco General, all low-income patients, to say, which one do you like better, the low literate one or the original? And this is the prompt: act like an ER doctor, doing these things. And what we found is that, yes, in fact, it could rewrite them, taking the atypical use down from 6% of words, 6% of sentences to 1.7% of sentences, and otherwise doing a good job in eliminating abbreviations and spelling and grammatical errors. But they were only able to maintain the clinical equivalence in about 80% of the discharge instructions. In other words, as they simplified, they lost information. And we found that 8% of the sentences were rewritten and had potential harm. For example, this one is no harm. The doctor says, use a sling and rest and ice and elevation for the ortho fracture. And here it says, rest your body, use a sling, and elevate the injured part. Okay, no harm. A little bit, they forgot to say use ice. Here we have an omission that probably won't hurt the patient, though it's suboptimal. But here, the original said, if you develop a headache, you can take Tylenol and only take a maximum of 3. And in the rewritten, it said, if you get a headache, you can take a pain medicine like Tylenol. Obviously, here is someone who fell, and we would prefer they not take nonsteroidals. So when we showed it to patients, so can it do low literacy? Yes. Does it lose information? Yes. Can it introduce harm? Yes, and rarely. When we showed it to patients, here's one that we showed them. You were evaluated for anxiety and alcohol intoxication, et cetera, et cetera. And here are the rewritten. We checked you for feeling anxious and drinking too much alcohol. And another one where one set of instructions had all the ER, the chest X-ray findings. The other one, it took out the chest X-ray findings. But what we find is that some patients prefer the rewritten and some do not. So among our low literate patients, the green, like here in the English, shows us, among English speaking patients, show us that most people were either green or pink. The light green is that they prefer the rewritten instructions. For Spanish speakers, on the other hand, the findings are all over the map. There's lots of colors there. Some prefer the original, some are neutral, and some prefer the rewritten instructions. Among patients with adequate literacy, there was also a lot of variation. So what did we find? And here's what the patient said, that more information is empowering and respectful. I like the original. And I like it because the clinical language is professional and non-judgmental. Others, who like the rewritten, say the clinical language is anxiety, and the simple instructions are helpful because it leads you to take actions more directly. So in summary, where are we? We have found that that GPT is able to reduce jargon, spelling, and grammatical errors and make things much more low literate friendly. It preserves meaning about 80% of the time, with 8% of changes possibly resulting in harm to the patient. But that patient preferences are highly variable. And at this point, that we think that physician oversight is still required before sort of having ChatGPT or other AI routinely make our documents more low literary. Obviously, lots of limitations. We only evaluated one AI model, but it's still it's promising and interesting. So let me just stop here, except to say that I know you know that language barriers contribute to healthcare disparities, that it makes the healthcare much less patient-centered, and that comprehension and trust tend to be less, that many outcomes are worse, particularly outcomes where patients need to understand things and trust the physician, and that much, much more needs to be done on a system level and external to a particular health system to facilitate language access. I am feeling that technology is already and will be increasingly very helpful, but we need good research to determine how to improve language access and how language barriers and technology will improve both the communication and patients' sense of trust in the encounter. So with that, let me just thank you, and I hope we have time for questions.
See, I was right. Amazing talk. Thank you, thank you, thank you, thank you, thank you. So I'm going to start with one of the questions that somebody typed in. They were talking about how in their scholarly work, they see that people often use a binary for it, like done, not done. But in the truth, the interpreter could have been used just for a couple of minutes. So how do you figure out the continuous rather than the categorical?
Yeah, great question. And I think that the study that I've done that I think has been most helpful for me with that is when we ask, for example, about key things in the inpatient hospitalization, admission, clinical rounds, discharge, family meetings, and really asking in some ways. In many times, if people take the trouble to call the interpreter, they'll often keep the interpreter for the entire clinical encounter. But I think that you're bringing up a true point, and if we had an automated system, we could track how long the interpreter was on the phone for, or how long the interpreter was present for. We don't have that now.
Another question is about language concordance. Whose view is it? Is it a patient or a physician view? And is it native speakers versus non-native speakers?
Yeah, great question. I didn't get into this, but we've looked at what we've done is in these studies, we survey the physicians as to their degree of Spanish proficiency. And we've done studies where you compare that to what the patients say. And in fact, when the doctor says, I speak Spanish very well or well, patient says, yeah. And when the doctor says, I speak no Spanish or poorly, the doctor says, the patient says, yeah, my doctor doesn't speak Spanish. The problem is that the modal response is fair. I speak some Spanish. And when you say that, patients split. About half of them say, my doctor speaks Spanish, and about half of them say they don't. So in these studies, what we've done is only taken as concordant people who self-report that they speak excellent Spanish.
Thank you. I have another question that Lynn Richardson, who can't be here, and Gordon Nye, who you used to mentor, who then Lynn mentored, they did a study here at Mount Sinai where they were looking at sepsis and finding that if you looked at English and Spanish speakers, there was no difference in mortality for sepsis. But if you looked at non-English speaking people who had less common languages, as you have in your practice, we also have here, in that population, they had a much higher sepsis mortality rate inpatient. They both asked me to ask you about your comments on what we do about, I don't know what you'd call these languages, minority languages for that group, or what do we do? Are other people seeing that kind of signal that these populations are more trouble, and other than providing better use of interpreter services, what do we do about this?
Yeah, great question. And we're seeing that signal in study after study after study. because clearly there are enough people around who speak Spanish, either because they're heritage speakers or because they learned it in school, that there's a lot more access for Spanish speakers. So I think we absolutely have to make interpreter use more seamless, right? So as someone said, so that you can just use it for a few minutes. But the other thing that we need to do, I think that is really what will help the other languages most, because the other answer is that we need a more linguistically more diverse workforce. And that is an area which may be stymied currently.
All right. We have a question from your old friend Nina Bikel. Um, Nina asked if you could talk about the impact of policy and reimbursement on language discordance and health outcomes.
If the question is about policy and reimbursement on language discordance and health outcomes,
Yeah, the impact.
there is no the reimbursement. To my knowledge, it was only Medicaid that paid extra for interpreter use. We don't. I don't know that there is, and if you know, that would be something I would love to look at. But we don't get to we're not reimbursed more if we're working with an interpreter. That's why so many people always say how this is an unfunded mandate and it's not fair and so on. And it's one of the reasons that many health systems give for not improving their interpreter systems. But if you know differently, I would love to hear that.
Nina, I don't know if you wanted to comment back on that, and if Nina's enabled for voice. Okay.
I think there's someone in the chat who is also a Star Trek
Yeah,
fan.
Claire Crunk. I think this is a really interesting question. Do you want to read it out loud so they don't get tired of hearing my
She was thinking about a particular amazing episode of Star Trek that everyone should see, no matter, doesn't matter if you're not interested in Star Trek. It's called Darmok and Jalad at Tanagra. It's called Darmok, the episode. And it's about a culture that only speaks who only conveys meaning through stories and gives and alludes to stories as a way of conveying meaning. It's fascinating, incredible thing. And what she's asking is, what do we do when the patient is trying to tell us something, but the interpreter doesn't have the word for it in English because the concept doesn't exist? Or for that matter, when we're using a word for which there's no concept. So whenever I'm doing having a conversation about advanced directives, the Cantonese interpreters, Cantonese, hospice, Cantonese, hospice, because there is no word. So these are really hard. And this is where the clinician has to be sensitive and where the patient has to be able to trust that they can sort of talk around a concept. So thank you for asking that question, because sometimes I worry that I oversimplify how difficult it is to take care of patients across cultures. It's so much more than language. It also has to do with referent concepts.
And I'll say, Alicia, you and others have showed us that, one version of participatory research is with the interpreters as your research partners, because they can,
That's right.
We have this with genomics. People are coming in and interpreters are saying to us, you're putting us in an impossible situation. I can't interpret these things. And so them as our research partners can really be important.
Yes.
We have 30 more seconds. Is there any closing words you'd like to give? I'd like to share our immense gratitude. This has been inspiring and fascinating, and you can tell our folks are already fired up.
Well, thank you very much again for inviting me, and I hope that this was useful and that you can take some of this into the clinical space. And for those of you who are researchers with the group, I hope that you can think, if any of you ever wishes to do research, you have a lot of great language researchers locally and on the East Coast, but I'm always eager, happy to work with young investigators.
Thank you. We know. All right. Thank you, everybody. We're going to say goodbye for now. Alicia, we have a little tiny meeting with you separately. Thank you all for joining us. And please, when Dr. Fernandez makes an offer like that, say yes. You won't get it very often. It's a very, very big privilege to work with her. Thank you so much. Bye.